Okay, we will get started for this afternoon now that we have Dr. John McGavick. So, it was a great morning. I just absolutely loved our two keynote speakers who are still with us. And the new investigator part was absolutely very stunning and interesting and really set the stage for an afternoon. This afternoon, so I am guided with wisdom and insight by my board of directors for the Manitoba Institute of Child Health, and they are chaired and kept in line by Shelley Werner, and she's here to bring greetings on behalf of the MICH Board of Directors. Shelley?
I have to thank you, Terry, for not forgetting me this year. So thank you for that. Also, your kind remarks about guidance and wisdom and everything. I'd like to listen to what I have to say, so thanks. So that said, what do I have to say? I am Shelley Werner. I am the chair of the board of directors of the Manitoba Institute of Child Health. And I want to thank you all for taking part in this 9th annual Child Health Research Day. And we are celebrating child health research and all of our wonderful researchers and staff. At MICH, we have world-class pediatric medical researchers, technical staff, students, and support staff working hard every day to improve the lives of children across our province. And that said, this is where I'll tell you a little bit about the fact that our board is comprised of also a wonderful group of people who are scientists, medical professionals in all ranges, as well as lay people like myself who are completely new to the world of science. And some people are laughing at this very moment about how I had to grab them in looking at the posters and say, what was my word of the day that I didn't know? Adiposity? Is that it? He said to me, it means fat. So I said, well, fine, just let's call it fat then. But the point is, it is really our job to help translate the activities that happen in MICH into the values that we have chosen to believe are important in the Institute, and the values about children and child health and the value of research and bringing it from the bench to the bedside. So all those things are what motivate us and the other lay people and the other board members that I see here to participate in something that tends to be way over our head. I don't know if the young man who had the project that talked about how you need to have 60 minutes of exercise a day. I don't know if he's here in the room. And I just basically said, what? 60 minutes? I can't do that. And he said, well, you're not a child, ma'am. You have to be a child. So, that said, I really shouldn't be allowed to wander around, but I do. And the reason I do is I believe so much in the cause. I'm so very proud to be associated with Dr. Klassen and all the rest of the wonderful team at MICH. So thank you very much for attending, and have a wonderful day.
We have 4 board members, too.
I think I alluded to that.
Yes.
There are 4 board members. I see 2.
And then there's this Jim Davey and Barb Trigg-Rain.
Okay, well, thank you all for coming. You guys are the reason that we can make valuable contributions to their team, so thank you.
Well, I think lay people or citizens sometimes undervalue their contribution. We've done grant reviews, and the final result is the lay people. It's almost the kappa between the agreement between the lay people and the scientists is pretty amazing. So there's probably more commonality and insight than they probably give themselves credit for. Anyways, I'd like to ask John McGavick to launch this afternoon and introduce our afternoon keynote speaker. John?
Thank you, Terry. It was quite a pleasure to see the speakers this morning. I was telling everyone how proud I am to be a MICH member. I've watched this group evolve over the last 5 years, and I now feel like I'm a little more of a senior investigator. And I'm up on stage introducing one of my favorite collaborators, Dr. John Walker, who is a full professor in the Department of Clinical Health Psychology at the U of M. And he's one of our university's most outstanding clinician scientists. There are 3 reasons why I wanted John to come up to present today. The first, when I present my work in obesity and type 2 diabetes in youth, the first question I usually get is, have you talked to John Walker? You guys should collaborate. Number 2, John's an avid cyclist. There's a grad student, I don't know if she's here, who had a meeting at the Fort Garry campus in February. John rolled in on his bike, riding from St. Boniface all the way to the Fort Garry campus, so that's check number 2. And then check number 3, John's specialty is in anxiety disorders. Whenever I leave a meeting with John, my anxiety levels are down, significantly down. So wonderful collaborator, great person. I think you're in for a pleasant surprise this afternoon. So Dr. Walker, I invite you up.
I want to thank the Manitoba Institute of Child Health and the University of Manitoba for inviting me today. It's been a very interesting morning and looking forward to a great afternoon. My topic's kind of complementary to a couple of presentations this morning, and I think very much fits with what we covered this morning, and I hope gets more into the area also of prevention and health promotion. So what I'd like to talk about is how can we help parents and schools to support resilience in children. And I want to recognize a couple of people I worked with on this. We did a book chapter on mental health promotion in the schools, and Dr. Barry Mallon and Dr. Benjamin Levin, 3 of us worked together on the chapter, and a lot of the concepts about resilience come from that work. I want to ask a little bit about you. First of all, could you raise your hand if you're a parent? Good, good, good. Lots of parents here. Raise your hand if you're a grandparent. Good, good. Okay, so there'll be a lot of interest from that angle. I want to ask who in their work is both a researcher and a clinician, both roles. Okay. Primarily a researcher, primarily a clinician. Okay, good. I want to tell you a little bit about me before I get started. First of all, I'm a parent. I've got 2 grown-up children and 1 grandchild now. And with my grandchild, I'm discovering all the delights I went through as a parent with a little bit more breathing room. So it's great. You can enjoy their company for 5 or 6 hours and then go home and rest. And it's a really great life. So I hope everyone here makes it to that point. There's been a lot of talk in research and the media lately about resilience, and I heard the term used a lot before I really understood what it meant. And it's worth spending a minute to understand this term and how it evolved. So resilience isn't a thing that you can measure like temperature or characteristics like that. It's a process. And it looks at positive adaptation within a context of significant adversity. So that's a big mouthful of words. But there's 2 ideas there. First of all, exposure to adversity. So the first work on resilience started out by looking at people who had particularly difficult life circumstances. Very difficult things happen. And in a way, they were searching for what made people sort of superhuman, that they triumphed over great adversity, and that's where it started. And as time evolved, what they found that having great adversity is very difficult, and we learned more by actually studying it in a broader population. So it's been studied now in populations with a wide variety of adversities, and there's been a lot of work on this. And the second part of the idea is positive adaptation despite major assaults on the developmental process. So, so the initial research focused on characteristics of the child. So what about a child made them respond well in the face of adversity? But later research suggested that was really way too limited. We had to look at a much wider variety of the factors, the characteristics of the child, aspects of the family, that's really, really important. And finally, characteristics of the wider environment, the community they grew up in, the particular neighborhood they lived in, and issues like that. So people have looked at in various circumstances, positive outcomes in high-risk children, sustained competence of children when they're under stress, and good recovery from trauma. And so the work in this area started in the 80s and 90s, and we now, in understanding resilience, have the benefit of a number of really good longitudinal studies carried out by developmental psychologists and other specialists, where they followed kids 20 and 30 years after that growing up period. One day I want to write a paper with a title like this, Ordinary Magic. This is a really, really terrific paper and a great title. And the concept here was that while early on people saw resilience as being rare and very special, the research indicates that resilience is really a common phenomena, and there's all kinds of developmental processes, all kinds of normal processes of learning that lead to resilience. So rather than being a rare and unusual thing, it's rather the norm, but we can still learn a lot by studying it. One of the advantages of taking a resilience point of view and a health promotion point of view is that good health isn't just the absence of illness. It takes a lot more to make good health. And if you look at what's associated with resilience and you work in our communities to develop those characteristics of people, that strengthens people for when they encounter a stress or a health problem or some adversity in the future. Another really important concept here, and this is probably the most technical thing I'll talk about in my paper, is developmental cascades. And what this talks about really is that through a child's life, there's many interactions and transactions that go on in the environment, and the effects spread over time. So if you study and hit on key issues early in life, that can build in strengths or disadvantages that are seen showing up later in life and in other fields. Just take a minute to read that definition. And this fits really well with our talks this morning. This is an example of some thinking about a developmental cascade involved in the development of aggression in youth, trouble with the law, and so on. If you start on the left-hand top, that's you can often look and study those phenomena around kindergarten age or preschool age. So children in certain areas of Baltimore are growing up in very difficult circumstances, and many areas of Winnipeg too. They're growing up in areas with high unemployment, families that aren't so cohesive, economic disadvantage, poverty, poor nutrition. And in this model, the next thing that often comes in there is early harsh parenting. So you may have parents involved who are quite young themselves, maybe not totally grown up themselves, haven't had good education about what's involved in good parenting, so that's a risk. And if you look at the arrows keep going towards the adolescent violent. Each of these sequences in the chain feeds into the development of violence in adolescence. The more disadvantages and problems here you have, the more risk. So the next one in the chain is poor school readiness. So children who are growing up in disadvantaged circumstances, parents with less education, less resources, and so on, often have poor school readiness. Another step down the road can be conduct problems in the home and in the school. School failure, so children aren't motivated or excited about being in school. What I often find when you see kids are having a lot of trouble with conduct problems, parents just get kind of defeated and discouraged, and they do lower parental monitoring, trying less to influence the environments their child is in, and then tying up with deviant peers is kind of the icing on the cake. So that's an example of a developmental cascade with very many different factors having inputs into that cascade, and each one sort of builds up disadvantages and risks in the young person. Not every young person would be exposed to all of these in this kind of situation, but when you add all these together, they really add into the risk. This is an example of a negative developmental cascade, but there's also examples of positive developmental cascades. So at the parenting level, that second box on the left, if parents are particularly skillful or talented, if they have good support from grandparents, if you intervene there with support to parents, helping them develop parenting skills and so on, you can take a child off the track of being at risk for violence and aggression and get them onto a more positive track of success in school, motivation, and those sorts of things. So in the developmental cascade view of things, the earlier you intervene, generally the better, the earlier in the chain. So you can see developmental cascades looking at positive factors, negative factors, and one of the examples is from the city of Baltimore, actually, called the good behavior game. And in this research, some specialists in child behavior were involved in the schools in Baltimore and worked with some teachers there. And they developed a very simple game that was played in the classroom called the good behavior game that worked with the children on cooperation, engagement in their schoolwork, helping each other, those kind of variables, really encouraging school engagement. The children in this study were from very disadvantaged backgrounds, lots of families with very low income and disadvantaged circumstances. The resources it takes to run a good behavior game, it uses a lot of emphasis on kind of motivation and rewards, but the rewards are very low cost. So the reward might be going out 2 minutes early for recess, if you worked well in the morning and so on. A lot of it depends on the teacher's sort of enthusiasm and being well organized and so on. But what was interesting, this was done in grade 1 in Baltimore, and then this group of developmental specialists followed up the children for about 20 years afterwards. And when they followed them up in grade 6, children who had 1 year of exposure to this had better academic achievement, less behavior problems in the school, functioning better. When they were followed up in their mid-teens, there was less problem with drug abuse. And this was, again, I emphasize, this was an intervention in grade 1 that stopped. So it was over with at the end of grade 1, wasn't a costly intervention. And in the teens, they saw lower drug abuse, lower teen pregnancies, I think, less involvement with the juvenile justice system. And into adulthood in this population, they were seeing lower rates of anxiety and depression, fewer suicide attempts, and less involvement with the legal system. So this is a good example of an intervention early in a developmental chain that really has an impact down the road. So what factors promote resilience? I'm not going to ask, I'm going to ask you to think about this, but I'll show you a list in a minute. I should have mentioned, after lunch, I often have a siesta, so if I was out there, I'd be having a siesta. If you're having a siesta, we're going to have a participation part later on in the meeting, so you may get to join me for the participation. So take a minute and look through this list, and none of this is going to surprise you, but it's interesting. These are all areas where there's very strong scientific evidence from longitudinal studies in children. So if you look at these characteristics, if you look at the first two, these really, really relate to parenting. So if you grew up in a family where your parents are positive and confident and so on, you've really hit the jackpot in life, and that sets you off on a really good scale. And the last point, effective teachers in school. So if by the time you hit school, teachers are effective and engaged and enthusiastic, again, it makes a big impact on what's going to happen in your life. It really builds in factors that make you more able to cope with adversity. Many of the points that go below the first two, intelligence, self-regulation skills, efficacy and control, those are things that parents teach in the work they do every day. They may not realize they're teaching it, but that's what they're teaching in the work they do every day. And what systems are most influential in having an impact on that list of 10 or 11 things? Well, the places where children spend most of their time. So the time they spend with their parents and other caregivers. And where can you reach children? Well, early childhood education, schools, and relevant to this audience, in the healthcare system. So every family in Manitoba almost every family, when their new baby comes home, get a public health nurse visit, where the public health nurse brings them information, checks out how they're doing, and identifies actually families at risk now in Manitoba and follows them up with extra support for the next 2 years. So there's a very proactive system here of kind of support to parents. Some of this research, again, was probably done in Baltimore and the East Coast. Some of the, I think some also in Australia, of the nurse visitors to home when children were young. And again, there's been a very strong evidence base that that kind of visiting has a real lasting impact on children's development. There's a lot fewer gray hairs here than I thought they might be, so the time frame might be different, but some of you may have heard and read about these things. I'm going to ask you to actually pull out a piece of paper if you can. I want you to really think about what's changed in the world in the last 50 years in the life of children. What have been some of the dramatic changes for children in the last 50 years? I'm going to ask for volunteers, and if I don't see volunteers, I'll select volunteers. So think about that. Yes?
More working mothers.
Okay, so more parents working outside the home, fewer parents at home during the day. That's been a big change. Good. Yes? Electronics. Very dramatic change. Yes? Nutrition. What do you think's changed about nutrition?
A lot more processed food.
Processed food. Yeah.
Availability.
Yeah. Tremendous availability of processed food. Yes?
Parenting style and also the educational styles.
Okay, so parenting styles have changed and education style. Yes, there's been some dramatic changes there. Yeah. Divorce. So yeah, so maybe more single-parent families than there were at one time.
Community planning.
Community planning. Yeah.
Physical environment.
Okay. Yeah. Or in Winnipeg's case, absence of community planning. Yes.
A widening gap between the rich and the poor.
Yes, boy, that's a dramatic change. A widening gap between rich and poor. Very, very dramatic. So I'm sure you can think of others, but what's striking is how much change there's been in the last 50 years. Okay, and it's interesting when you talk to the public about this, and also when you talk to parents about this, what parents' perceptions are. Some parents perceive that over the last 50 years we've come to live in a more dangerous world. Okay, I'm going to ask for a show of hands. Is it true that we live in a more dangerous world now than we used to? Not many hands. Okay.
North America, I'm assuming.
Pardon me?
You're talking about North America.
Yeah, in North America in particular. If Sub-Saharan Africa, it's different. But in North America, yeah. So the public has this view, actually, that we live in a more dangerous world, more kidnapping, more murders, more bullying, more crime. All not true. All not true. All these things are significantly lower over the last 50 years than they were 50 years ago. A way I get to parents about this is I say, actually, Winnipeg is a much safer place now than in 1912. In 1912, Winnipeg was much safer in 1812. In 1812, Winnipeg was much safer than 1712. And so the safety in the world has continuously improved, but what's changed probably is the perception of danger. So in 1912, if there was a murder in Selkirk and you lived in Winnipeg, you might not have heard about it. But now if there's a spectacular murder in Dallas, in Bangkok, in London, you'll know about it within half an hour probably if it's a spectacular enough crime. So this perception of danger in the world is one thing that's really changed. I get reporters asking me all the time, is the world more stressful now than it used to be? If kids have anxiety and that's what you work with, is the world more stressful? And my usual answer is to say, well, boy, family life can be stressful and the world can be stressful. But, 100 years ago or 150 years ago, it was stressful too, You're worried, this time of year, you'd be worried, do we have enough food to make it through the winter, That was a stress. Will one of my siblings die this year? That was a stress 150 years ago. So our stresses have changed. I don't think at all you could say it's a more stressful world than it used to be. I think when I was a kid, kids were getting polio down the road, that kind of thing. So there's some real misperceptions out there in the world about what's going on. I think some of the things going on are sort of happening very quickly, but an inch at a time, and people miss them. So what about TV, computer, and video games? Okay. If you look at national surveys, the amount of time that kids spend each day doing video games and television and so on has just gone up and up and up and up. So it's a big, big impact. What other things have changed for families? Thinking about in urban communities, like a large community like ours, smaller family size. So family size over the last 50 years has really, really changed. Fewer kids on every street. So there's a few other people in my era here. When I was a kid, the normal parenting behavior on Saturday was to kick you out of the house at 8 in the morning and tell you not to come home till lunchtime. And you had lunch at home, and then they kicked you out again and said not to come home till supper time. And after supper, they kicked you out again and said not to come home till bedtime. And I think the supervision in those days was pretty light, too, by parents. But there were other younger children to take care of, and it seemed to work. Nowadays, I've talked to parents in Winnipeg, living close to St. Boniface Hospital I work, and they may send their children out in the front yard or backyard to play, but they're worried about their neighbors complaining about them being neglectful and so on. So the world has really changed this way, and that's brought some other differences. Children attend diverse schools now. So 50 years ago, you all went to the same school that was about 6 or 8 blocks away. Now, in the neighborhood where our kids grew up, you could go to French immersion, Francais, English, church-run schools, the whole gamut. And on any street, there'd be kids going to 3 or 4 different school systems. And that actually has implications for families. I'll come back to that maybe later in terms of friendship. One of the concepts here when you're trying to sort of build resilience and have an impact here is when you think about resilience, that was a big long list and there's 100 things you could work on. Sometimes there's an advantage to trying to bite off one piece of the cake at a time. So parents, when they come to see a practitioner, when a public health nurse sees them, when they go to see their pediatrician, often they have a top-of-mind issue they really want to talk about this week. And if you can help them to problem solve about that, often you have more of an impact. The concept of developmental cascades suggests that intervening early to have an impact can have an impact on everything that comes afterwards. So some of this concept is to really push towards putting resources in early in life. And then you can, it's easier to develop a healthy pattern early than to change an unhealthy pattern once it's been in place for 5 or 10 years. So one of the topics, and maybe I could have, if I could have a couple of people that might help out with just distributing some handouts. Thanks. So if you just pass them down the rows, that'd be great. So one of the things that caught our attention in our work is the issue of screen time. This caught our attention in 2 ways. First of all, we've been doing some work on sort of promoting healthy eating and healthy physical activity. And one of the things that competes with healthy physical activity is screen time. So that's one reason we're interested in it. Also, I work with childhood anxiety, and I see we see in our clinic a number of kids with school refusal. Could you put up your hand if you know what school refusal is? Okay. So school refusal is child, often it's grade 5, 6, but it might be 7 or 8, who refuses to go to school. And there's big battles at home, and often what is keeping them at home out of school is some kind of health concern, stomach problems or that kind of thing. And in meeting with families like that, almost universally, every family I met, the children who had school refusal problems had unlimited access to television, computer, games, and so on. So that was what was competing. So we started to look at, what are some of the impacts of increased screen time? As screen time's gone up, physical activity's gone down. There's increased problems with overweight for children and adults. And our hunch in our work with children's anxiety is that screen time competes for time with friends, actually, for the times that people used to spend in free play with other children. Screen time's taken over a lot of that time. So this handout that you have in front of you, I'd just like to talk about it a bit. We developed this as a tool to use with parents. I'll just walk you through a page at a time. If you look on the second page, if you fold it over, what we found, we did a lot of work with parents, kind of giving us feedback on this and getting the reaction. And one of the points we get is parents are rushed, so you want to give them the key points right away. So on the left-hand side, page 2, key points and key actions. And we really worked to get this into plain English. And we tried to give them practical advice of things that parents could do. The first 2 points, take charge of your child's screen time and establish family rules. That was a foreign concept to some parents, that actually it was their job to establish some limits around screen time. In their family, they thought their job was to try to convince the child they should do something else instead. And if the child agreed, they would do something else. If they didn't agree, they'd have their screen time. So it was sort of a very highly democratic, but a 6-year-old got the same weight in their vote as a 26-year-old or a 36-year-old. So not the best situation. Just take a look down that list. Point number 4, screen time is a privilege, not a right. That's a shocker to some people. Separating viewing from chewing. So turn off the television, turn off the media during meal times. Keep screens for children in public areas of the home. So some of the children that we saw that had trouble with not going to school had a television in their room, a computer in their room, and often that's where they spent their time. That was their friend, really. That was a big impact. A really tough one for some parents is being a good role model. It's hard to limit children's screen time if you're spending all your day or a big chunk of your day interacting. It's hard to have them have the TV off during dinner if you want to have it on during dinner, or if you're taking phone calls or that kind of thing. If you flip the page over, one of the things we found is that on the internet and other places, there's lots of advice for children, for parents, but there's very little advice to do about what to do when you run into a problem. So we actually spoke to parents about the most common problems when they tried to limit their screen time, and we outlined some of the challenges parents might meet and how they might respond to that. So suggested some good parenting responses. On the last page, we encourage people to make a schedule for when TV or screen time. And this includes computer and iPhone and iPod, every kind of screen. It includes that all in there. If you want to not find out how much time a child spends on the screen, ask the parent how much time their child spends doing that, and you'll get a low estimate. It's kind of like asking someone their weight. You'll get a low estimate. If you really want to know about how much time a parent or a child spends doing screen time, is not to mention screen time and ask them about a typical day. What happens when you get up, and then what happens, and then you go to school, what happens when you get home, what happens before supper, what happens after supper, and so on. And we actually had parents in some of our programs track this, and the parents were shocked about how much time each day was spent in front of a screen. So we worked with parents to try to limit the screen time to an hour or two a day. We don't have data on that right now. We've been just working it out as part of our programs. But what we found that when you gave parents, some families come in and they're totally on top of this right at the start. They know exactly what they have to do. It's not an issue for them. And other parents hadn't thought about it at all, thought that their child had an equal vote to them in terms of whether they'd be watching television or not, that kind of thing. So we found that when people tracked their screen time, they were quite shocked about it. I think all of us know that behavior change is difficult. One of the challenges of screen time is it's so seductive. I was babysitting my grandson, I think when he was about 10 years old, and usually he goes to bed really easily and whatever. This night he was fussy. And so I was walking around with him, and all that kind of thing. Maybe he was more like 8 months old, walking around with him and carrying around, just wouldn't settle for bed. And so I figured, well, I'm going to be pacing and living with him. Maybe I'll just turn on Peter Mansbridge, you know. And it was like a rocket. On comes Peter Mansbridge, and his head's over there, you know. Interested as anything. I didn't realize he was interested in the National at 8 months old, but he was very interested. So I think changing that behavior for some families and so on, it can be very, very difficult. I've talked to some parents about it, you know, about turning off the television during meal times. Parents and families where everybody eats in their own room or in front of their own TV or that kind of thing, and they have a real struggle to do that. So behavior change isn't easy, but when you accomplish it, it can really pay off. So you're probably familiar with the recommendations about screen time. There's very good data from community-wide studies that more screen time leads to poor performance in reading, physical activity, time with friends, and we talk to parents about learning practical skills. You learn better by doing than by watching. Watching is good for the early stage of learning, but in the end you have to do something to actually learn it. So talking about now how in the community would you apply this, we've worked with some people who sort of work in community-wide programs, and if you take a public health model, what you don't want to be doing is just dealing with people who come in with a problem, dealing with parents who come in with behavior problems in their children, whatever. You want to get out and get this into the community. I'd like your thoughts here about maybe just think about it for a minute and put up your hands. What's the best age in a family to introduce some rules and limits about screen time? Think about that for a second. Any ideas?
Well, I think at birth, because people are doing it well before 2, but then again at 2, once you say, okay, it's now time.
Yep. Yeah. Exactly. So if you leave it till children are, and we have kids coming into our clinic who are 16 years old, don't go to school very often, unlimited screen time, changing with a 16-year-old, you can have a fight on your hands. If a child experiences it from age 1, age 2, age 3, age 4, that our family has some rules about this, and there's some limits, and there's some say about who watches what on the screen, I think people are way more, will have an easier time to accomplish that starting at a very early age. So we advocate doing it very early. So if you take a public health point of view, and you want to get this information out to people in this form, in discussions with healthcare providers, and discussions with educators, how do you get it out there? How do you get it out so it's going to get to most people? Any thoughts about that? Commercials, yeah. I heard that, yeah. And it's probably true. That's a good way to get out there. Sort of media campaigns. Hands up, any other thoughts? How do you get out to people? Yes?
Daycare centers?
Yeah. Daycare centers. Other ideas? Public health nurse visit. Yeah. So in developing the material for this, we worked with public health nurses in a couple of areas of Winnipeg to get their input about the concerns they hear from parents and the issues they hear from parents. Any other ideas? Schools. Yeah. So the idea that we're working on right now, and we're working with schools and other people to, first of all, can you get the public health nurses to introduce this right when parents come home with a new baby, to get them thinking about what their rules are going to be about these kind of things, about screen time, that kind of thing. Can you get to them again when they're going into a family doctor or a pediatrician for well baby visits? It's another time to get them. Many children now are in early childhood education programs when they start there. So our view of this is kind of reviewing this with parents almost at the start of every year. Because if you look from a public health point of view, where are the areas where we've had success? Well, there's been tremendous success with child car seats, seat belts, some of the things on how children sleep at night. We've had a lot of success, and it's been an educational push, but sort of a total community push in informing people about this. So this is one thing we're working on. We've also worked on materials on the same line on promoting healthy physical activity, kind of the same thing. You want parents to be aware of physical activity, not when kids are 13, but early in life, and make it part of their life from early on. And the same goes for healthy eating and healthy beverages. So different prevention and promotion programs differ along different dimensions. There's variability in their evidence of efficacy and effectiveness, sustainability, going to scale, which means going right up to the community scale, a whole community approach, and how sustainable they are system-wide. There are differences between programs in how much they cost, what's associated with training, implementation, sustaining it, and longer-term costs and benefits. And I just want to talk about a couple of examples today. Could you put up your hand if you've heard of the Triple P program? Okay, so a lot of you have heard about that. That's one that actually I was involved in with some other people. We actually brought this program to Manitoba when it first came. And it started out in Australia, and it's around North America now, in the US and so on. But we were one of the first jurisdictions in North America that they actually came and talked to us and so on. And there's been a big investment by the provincial government in training of staff and so on. One of the differences in the Triple P program is it doesn't require add-on personnel. So it always uses existing resources. Healthcare people, educators, other people in the community, influential people, the child education system, and it uses the existing system to get information out to parents. It's got a very sort of sophisticated model. If you look on the bottom level, there's individual work with parents, work with groups of parents, and self-directed work. So self-directed work is where the parents pick up the information and watch it themselves or read it themselves, that kind of thing. And it starts, on the left-hand side, you can see it starts at the bottom with parenting information campaigns. The next step up, level 2, is brief parenting advice. Next step up is narrow focus parent skills training. Step up, broad focus parent skills training. And then the last point is behavioral family intervention. This is more intensive interventions for families that are really struggling, having difficulty. So it's a very comprehensive system. One of the things that struck us to bring them to Manitoba is they've got such well-developed education programs, and they're developing modules now for diabetes, for children with autism, children with developmental disabilities, and so on. So they've got some very, very well-developed materials for parents. It has the strongest evidence base of any parenting program. And one thing that's kind of the holy grail here in terms of public health is evidence for change at the population level. So not the people that were involved in the program, but in a particular population area. So they were funded for a large study by the Center for Disease Control in the US. And I'm pretty sure it's North Carolina, they randomly assigned counties in an RCT to be involved in Triple P parenting programs or not. And at the end of the day, it went on for a year or two. And at the end of the day, they found lower numbers of emergency visits, less expenditures on foster care and so on because of abuse-related problems. And overall, the cost-benefit ratio was such that the reduced costs of the program paid for the training in the program and for the implementation. So it's very favorable sort of cost-benefit evidence. This program has been committed all the way through to sort of gathering evidence and RCTs and so on. And each component of the program, they've kind of worked to get good evidence that particular component works. So that's a really good example of a sort of population program. The skills they're teaching in the positive parenting program are all about resilience. So if you go back to that list we had early on, helping parents to help their child develop problem-solving skills, self-control, good intellectual development, and kind of commitment to school, pro-social kind of motivation to help in the community. So they really touch on a lot of the bases that you'd want to touch on in terms of promoting resilience. In Manitoba, I've got some stickers here afterwards. There's a fridge magnet you can pick up, just with information about Triple P. We'll put them over the front here if you want to pick one up if you're interested. There's a phone line available Monday through Friday, 8 to 8, and also toll-free for people outside of Winnipeg to get advice about parenting dilemmas and parenting problems. So that's a new development. I think that part might have been developed uniquely for Manitoba. I just want to talk a little bit about some of the other work we've been doing on early intervention to promote resilience in children with anxiety. We talked this morning about a whole variety in some of our talks and some of the shorter presentations about a whole variety of health problems that are serious but quite rare. So fortunately, it's quite rare. Children will have some of these conditions. They're very serious in their impact on health. But actually, if you do the epidemiology of it, children, first of all, in the population as a whole, are amazingly healthy. That's good news. But what are the common problems in the community? Okay. Almost all of the common problems in the community relate to mental health, intellectual development, behavior management, and so on. So the child anxiety, which is my area of focus, if you go into any school in Manitoba, starting in kindergarten, 1 in 10 children in that school is having a problem with anxiety. So think about that, 1 in 10. That's huge, huge numbers. People in the mental health field decided long ago that there would never, ever be enough care providers to provide help to people 1 at a time or 10 at a time or whatever. And that's why in our field there's been a tremendous emphasis on health promotion, resilience, what can kind of prevent problems and help people manage problems. One of the projects we've been working on is a web-based program for parents of anxious children. Most of those 1 in 10 children don't get any kind of help. Even fewer get an effective kind of help. So we're thinking about how to reach parents with help more economically, reach out more geographically, and so on. So we're developing this web-based program. We know that in Canada, about 80% of families, at least as of a few years ago, had access to high-speed internet at home. We were a bit worried about remote areas. I was talking to John McGavick about the Island Lakes area, and we said, John, what's the access to internet like there? Can people get onto the web? And John was telling me, the problem is getting people off of the web, not onto the web. So they're very well connected there in a lot of communities now. And so this is an area where there may be some promise. When we talk to parents in our clinical work, we ask them how they'd like to communicate. They want to communicate by email. It's much easier to set up an appointment that way than over the phone, that kind of thing. So they're very sort of web savvy. Our program isn't widely available yet, so I'll just talk to you about some of our thinking in developing it. We're just getting ready to do some pilot work on it. But I think the themes here of what we're teaching in the program relate to the area. Can you see that? I know the writing's kind of small. Can you see the writing on the left-hand side of the screen okay? Yeah? Okay. So if you look at the topics there, if you run down the left-hand side of the screen, that's the topics that we work on in so on. The first 4 or 5 topics are quite highly focused on anxiety, right from understanding anxiety to facing fears. But the next one, there's motivating your child. So a lot of parents are really interested in how to create motivation, sustain motivation about school. That was one of the points on the resilience thing there. Parents, when we've spoken to them, often just don't know which way to go. They're really searching for advice. First thing about when we meet with parents, a lot of them are doing great work. So they're very invested in helping their child, especially the parents of the really younger kids. They're doing great work, but often they don't know which direction to go to deal with certain problems. So motivation is high on the list. Problem solving. If you go out into the community, some psychology researchers at one time hypothesized that people with certain anxiety problems had poor solving skills, and most other people in the community had good problem solving skills. when they went out and tested that empirically, they found that most people had poor problem-solving skills. They were sort of disorganized about how to approach a problem, didn't have a systematic approach, and so on. So we work with parents on teaching their child in a very informal way problem-solving skills. You can see screen time is there, bedtime routines is there. All these points are there on the left-hand side because there were parental concerns. Friendships, you see it's the last one on the list. We're working on more modules, but that's one of the last ones we get to. We have this problem I mentioned early in the presentation about it's just harder to connect your child with other children now. There's fewer kids on every street. They're going to 6 different school systems. Parents often have to go to quite a bit of trouble. If you have your child playing on the front street, someone might phone Child and Family Services, some people worry. So it's harder to connect your child to other children. Some of the units we're working on, one we call encouraging cooperation, which involves managing child behavior, encouraging them to be cooperative, encouraging age-appropriate independence. That's one that's huge. Again, I see teenagers in Winnipeg that come with their parents who've never taken a city bus in their life, you know. And I say to the parents, well, listen, you know, they could learn how to ride the bus in Winnipeg. Would you rather they learn how to ride the bus in Dublin or Istanbul or somewhere like that, you know? They'll probably learn some good skills if they're riding the buses here first. And finally, managing intense emotions. That's one that parents are really interested in. A lot of these programs that are more preventive in nature, part of the idea is not waiting till children are referred. That's kind of, often someone has a problem for 5 or 10 years before they get referred for a problem when it comes to a mental health problem. So reaching out to early childhood education centers and schools and so on. With anxiety, it looks like it firms up a little bit more, child anxiety around 3 or 4. That it's quite variable until age 3 or 4, and then it firms up a bit around 3 or 4. And so we're targeting early childhood education centers and then schools again. So the idea is each year when a parent starts school, they might hear about, if you think your child's much more shy or fearful than most, you might be interested in this resource. So getting the resource out to people that way. We're working to make it very low cost, so there's no clinician time involved in screening the child, that kind of thing. We've picked a title for the program we think is appealing to parents, so we don't call it, you know, Help Your Poor Anxious Child program. We don't call it that. We call it Coaching for Confidence. So trying to have a really positive connotation there. The schools have a tremendous role in promoting resilience, and I think already they do a good job. Kids spend a large proportion of their waking hours in school, develop academic skills, life skills, lifelong friendships. How are we doing for time? Do I have 5 minutes left? Okay. So I'll try to...
Then you'll have 5 minutes for questions.
5 minutes for questions, okay. On this friendships thing, I just want you to think about this a little bit. Could each of you take a minute and think of your 2 or 3 closest friends? Okay. Your 2 or 3 closest friends. How old were you when you met each of those friends? Okay, 2 or 3 closest friends. How old were you? Okay, would you raise your hands if you were between, let's say, 5 and 9 where you met one of your closest friends? Just raise your hands. Okay, just take a look around the room. Okay, it's about 50% people that met their closest friends between 5 and 9. Okay, now 10 to 15, you met one of your closest friends. Okay, more hands up. 16 to 21. Okay, good, okay. So the message here really is that friendship is something that develops early on in life. Parents sometimes think that when a child goes to school or a child goes to hockey or soccer or whatever, they'll automatically make friends, and many kids do. There's lots of kids you don't have to intervene. But some of that 10% I talked about have trouble connecting with friends, and we worry about there being a critical period there, that if you don't learn some things about making friendships between about, 7 years old and about 17, learning how to do it when you're 22 is going to be hard sledding. You'll miss a lot of component skills and that sort of thing. So schools, I think, take an active role there in trying to promote friendships. Talking about another point about schools, I think I'm going to skip over this one. I can't resist. part of my career, I was a school psychologist for 3 years before I went to St. Boniface Hospital. A lot of parents think of schools as incredibly permissive, kind of disorganized places. I have rarely set foot in a school that wasn't 10 times as tight in discipline as most families. So a lot of kids who have behavior problems at school are much better behaved. Schools have much clearer rules, much firmer limits, and so on. I won't get into bullying because we don't have time. This is my cue. Just take a look there. The Arnolds feign death until the Wagners, sensing sudden awkwardness, are compelled to leave. So this is my sign to wind up my talk, and thank you. Any questions or comments on the sheet for parents, that kind of thing?
Thank you very much.
Thanks. Yes.
Thank you very much. That's really interesting. I have a son of 10 and a daughter of 7. They love watching TV and playing Minecraft. My son, actually, when he was born, my wife was watching a little bit of TV while she was breastfeeding him, and he would turn his head while he was feeding to watch the TV. So he had a genetic problem, I think. But the reason, this is all preventative measures. What do you think is behind that? Why are children so attracted to online stuff and rather sit passively behind the screen than go outside and play with their friends? Is there anything known about the reasoning for that?
Yeah, boy, what a good question. I'll repeat the question. So what's the reason that we see this? To be honest about it, I'm not sure. I just think it's, one of the things about television and computers and games is they're so interactive, compelling, they're so convenient. So the child just has to walk in a particular room in a house. Playing with a friend, you have to contact someone, organize time to get together. Are they going to be cooperative? A lot of other things that kids do just take way more organizing and calories. But there's a huge amount of money involved in TV and whatever, and you can think those people are thinking night and day about how to get you engaged and keep you engaged. Yes?
One of the things I've always been curious about in terms of the developing brain is that screen time is two-dimensional, but the world we live in is three-dimensional, and how that actually affects the ability to learn or to not learn how to interact properly in a three-dimensional world. The other comment I have, or question I have, has to do with your good behavior program implemented in grade 1. And I was wondering if there was any sort of, with the study, if there was any sort of sub-analysis done on children who might have higher rate of impulse orders, such as in the case of fetal alcohol syndrome, or some children who are sex abused in certain ways as children have a higher degree of impulse orders, and that whole connection between cause and effect is kind of severed. And so if there was any outcomes on that population.
Yeah. Good question. So I'll just repeat the question a bit. I'll try to summarize it. So in the research in Baltimore, was there any analysis of children that had things like fetal alcohol syndrome or ADHD? And I'm sure there wasn't. One of the perspectives, though, from research on ADHD and fetal alcohol syndrome actually is that really the issue there is motivation, and you just need to crank up the motivation. So kids with ADHD have an incredible attention span for computer games and things like that. They'll play them by the hour. And so one of the points of view out there is really what we need to pay attention to is motivation. With fetal alcohol syndrome, I think the idea that they can't connect cause and effect, I think, is just not true.
But there is a higher, and in certain cases you have groups of children with a very high sort of impulse behavior.
Yeah. So I think the base rate in the Baltimore population was very high for those problems, for ADHD and impulse control problems, and they still did very well. And in fact, it's even more important to have those kind of mechanisms of high structure, high motivation in place for children that have those kind of risks. So it's a really good question. Yes?
Thanks, John, very much for that talk. At the very beginning, you talked about the development of resiliency and the nature of the exposure to adversity and how parents cope with that. The implication being that there are some kids that are exposed to so much adversity that they there's not enough skill on the part of their parents or intrinsically for them to develop those skills. But I think we're starting to see also the opposite end of that spectrum, which is where kids firstly aren't exposed to adversity because they're either segregated from society in front of a screen, or their lives are hyper-structured by their parents. And I think we have a generation of kids who also, on the other end of the spectrum, perhaps the more affluent end of the spectrum, even potentially, who just don't experience resiliency and are so protected that they don't experience adversity and are so protected that they don't develop those skills. So I'm wondering if you can comment on that.
Very good point. Okay, so one of the things we didn't come to in our thing of how the world has changed. So the world's changed with more computers, more screens. You could have put there, the world has changed by having too much. Okay, so it's really not good for children to have everything they want when they want it. It's good for your child to want something and not have it, and to have to plan for a year to get it. Those of us with gray hair probably remember wanting a bicycle, and that was something that you'd plan over a year or two, and you'd save up money and that kind of thing. And some kids in some families don't get that experience anymore. When they want something, they have it, and so on. And so some of the social problems we run into are problems of excess, even with poor families. So children in families with less income, sometimes the parents go without and the children have $100 runners and that kind of thing. And so one of our messages in the motivation section of our program there is, it's good for your children to be hungry. Okay? We mean it there metaphorically. It's probably good for them to be hungry sometimes actually, but it's good for your children to be hungry metaphorically, and having them have everything they want as soon as they want it doesn't teach them problem solving, delayed gratification, and so on. So those are very important characteristics that we encourage parents to work towards.
There was this profound movement in Canada that, like Fraser Mustard and Clyde Hertzman, that success by 6, or like somehow the first 5 or 6 years of your life if you didn't have it right. And yet this morning we heard about intervening at youth and trying to understand that. What do you think about that? Was there an overemphasis on the early years? They are very important, but what's the current thinking on that?
Yeah, really good question. So is there overemphasis on the early years? I don't think there is an overemphasis on the early years. I think it's really worth investing there a lot. What that doesn't mean, though, is it's not also worth investing in the teenagers and so on. We all see stories of people turning their life around and so on. My oldest boy was kind of challenging at time. He was kind of a devoted D student in high school. If he got more than a D, he realized he'd worked too hard, And now he's a school teacher and loves what he does, and went to university and got good marks and so on. So it's never too late. And that idea about resilience being normal, that when someone gets off track, there's almost always a way to get back on track. But in terms of cost benefit, the dollars you invest in education, what Ontario is doing now with full-day kindergarten, junior kindergarten, that money comes back to you big time. I think you almost have to pay attention to it every step of the developmental thing. So if you invest all this money in children early, and in the middle part of their life is all spent during screen time, and they don't know how to read a book or whatever, you're going to have you'll lose that investment if you don't keep investing in it.
And then what about roots of empathy, taking babies into classrooms and having the kids hold them?
Yeah. That is fabulous. Yeah, just fabulous. And again, if you think of how the world has changed, a lot of us with gray hair, part of my growing up was changing diapers for my siblings and doing those things. Way fewer kids have that experience now. So a lot of children, if there are 1 or 2 children in a family, they don't have the experience of caring for an infant or understanding about an infant. So again, the roots of empathy, really getting children early in life to get them helping other kids. There's some really innovative programs where they have kids with some kinds of learning problems helping younger kids to read, and that sense of helping someone else really helps to build motivation.
That was fantastic. I do have one last question. 2 of the books that have really influenced me, I think, have been Viktor Frankl's Man's Search for Meaning, and most recently, Paul Tough wrote a book on, I think it's The Successful Child. Hope was a big, big factor, and you had it in there. And we talked a little bit about that this morning. How do we foster hope, especially in the teenage years, knowing that you can't always invest in the early years.
Yeah, yeah. I think part of it just engaging teenagers in pro-social activities. There's some really interesting research in California that involving kids in developing anti-smoking ads really increase their engagement in that. So parents along the road can help their children engage in the world. And this is where we're important as models. If we talk to kids about the world being dangerous and other people being unreliable and untrustworthy, our kids may grow up that way. If we show them the example of being engaged in the community, doing positive things, involving them in positive things, it builds in that hope and community sense that's really important.
Okay, great. Thank you very much. I think, do we have one more question?
I just want to put a plug because I think if you're talking about, we're going to hear about from Michael Champagne tonight, and he's doing that in our city and bringing a lot of teens towards that route.
I want to say you stole the words out of my mouth, but you didn't, so well done. Good plug. So for those of you that are planning to attend the dinner tonight, you'll hear a lot about hope tonight, a lot from Michael Champagne about, and Nick has something to say.
We need the participants in Dr. Goodbear's den to meet at the reception desk or right away, the registration desk. So we have half of our component, we need the other 5. So if you're in the audience, please join us. Thank you.
Okay, and so you have 20 minutes. We have to be back here at 3 o'clock for 3 sharp for Good Bear's Den. It's outstanding. And Dr. Walker has some. And please thank Dr. Walker one more time.